Good afternoon, everybody, and a very warm welcome to this webinar that has been developed by the Local Government Association, the Health Foundation, and the Department for Health and Social Care and the Office for Health Improvement and Disparities of the North West. And it is kindly hosted today by the Health Foundation. Thank you so much for joining us. My name is Councillor Louise Gittins. I'm chair of the Local Government Association and I'm leader of Cheshire West and Chester Council. So just a few pieces of housekeeping, which I'm sure many of you will be familiar with. First of all, the event is being recorded and will be available on the Health Foundation website within 24 hours, and a subtitle version will also follow. We'll first have contributions from our speakers, who I'll introduce and explain a bit more in a minute, and they will talk about health in all policies in practice that they've actually led and the impact that this has had on wider council approaches. There'll then be a short discussion which I will start off, but really importantly, we're going to be asking for questions from the floor. So again, if you've been on one of these before, you know that there is a opportunity at the bottom to post your questions. And if there's questions that you like, if you can give them a thumbs up, and then the most popular questions will be asked. So moving on, I'd just like to introduce our fantastic panel members that we've got here today. So first of all, we have Michael Chang, who is Healthy Planning Lead for NHS Property Services. He's also visiting professor at the University of the West of England, World Health Organization, Healthy Urban Environments, the Senior Research Fellow for the University College London and the Institute for Global Health. We've also got Kate Kennelly, who's the Chief Executive Officer from Cornwall Council, Sonia Mill, who's Project Officer from Glasgow City Region, and Catherine Merrifield, who is Assistant Director of Healthy Lives at the Health Foundation. Each of our speakers is going to have about 5 to 6 minutes to give a brief overview of their approach, and there's probably going to be some nice slides to share as well. So without anything more from me, I'd like to hand over to our first speaker and give a very warm welcome to Catherine Merrifield from the Health Foundation. Catherine.
Thank you so much, Louise. And hi, everybody. It's really good to be with you this afternoon. So as Louise said, I'm Catherine Merrifield. I work at the Health Foundation, where I lead our work on regional and local government. For those of you who haven't come across the Health Foundation before, we're an independent charity working to build a healthier UK. So a lot of our work focuses on the NHS, but a really key plank of our work at the Health Foundation looks at what we can do to address all the things that help people stay healthy in the first place. So things like decent housing, access to green space, good quality work, safe connected communities, all the areas that, as we know, local government has a real influence over. We at the Health Foundation are particularly interested in health and all policies in this context because evidence shows that when health is considered across all local policies, people are healthier and the gaps between communities narrow. I just wanted to spend a couple of minutes, and I've got a couple of slides on this, outlining some of the work that we've been doing in this space, as well as our wider work to support councils. So we're really keen that you go away today with some ideas and some things to think about in your own contexts. So I'm just going to flag some resources, most of which are available on our website, which you might want to look at following this session. And all of these tools and resources I'm going to talk about are key enablers of taking health and all policy approaches. So if it's possible to get my slides up, that would be great. But I will proceed anyway. So first set of things that we do to support health and all policies approaches is providing some of the kind of foundational information and support to local leaders. So I've put a few examples on this slide. Going from left to right, our frameworks toolkit, which some of you may have come across. This feels like a really important foundational piece of work, which is looking at how to talk about the wider determinants of health in a way that resonates with the public and decision makers. And I think as we'll get into that, speaking a common language about what are we talking about when we're talking about health in all policies, and reducing health inequalities seems really key. Some of the other things that we've done include a framework for local government action on risk factors such as smoking, diet and physical activity. And finally, to understand actually the situation in different councils, we've put together a local authority dashboard. This is a free interactive resource that presents data and insights on the state of health, health inequalities and the drivers of health across all local authorities in England. So I'd really recommend, if you haven't had the chance to have a play around with that for your authority, do have a look at it. Going on to the next slide, one of the other ways in which we try and support health in all policies approaches is commissioning work. So commissioning independent analysis to build the evidence base. So just a couple of examples here. We've been working for several years now with the Institute for Fiscal Studies to map how public spending is distributed across different local authorities and how the level of spend that different authorities receive relates to the level of need in those authorities. And this has been obviously feeding into some of the fair finance review work that's being done by MHCLG. We've also been doing some work with SIPFA to understand and measure levels of preventative spend in local government. So with a view to understanding how to baseline and identify what counts as preventative spend. That work is going to be published next week and will feature in a future webinar. So do look out for that. That should be a really interesting and useful piece of work. And then going on to my final slide, some of the other ways in which we support local action are direct funding to local areas. So we are going to be hearing today more about one of the outputs from a funding programme that we ran that ended this year. That was the Economies for Healthier Lives programme, and the Glasgow tool that Sonia is going to be talking to us about is a tool from one of those 5 projects that we funded. All of those projects were looking at how you can join up economic development and public health to improve health outcomes. Our biggest funding programme at the moment is with mayoral regions or strategic authorities to support and explore the role that they can play in improving health. So some of our funding is going on funding dedicated posts in strategic authorities and also funding a central team who are based in the West Midlands Combined Authority. They recently have produced a health in all policies toolkit, which I'd really recommend you have a look at. It is aimed at a strategic authority audience, but we've had some really positive feedback, including from a number of directors of public health, of the value of what's in that toolkit and the replicability in other parts of the system. So to conclude, we are here to try and give local leaders tools, evidence and insights to help embed health across all areas of council activity. What we're trying to do is support you to ensure that every local decision contributes to healthier and fairer communities. And I hope, as I said, that today's session gives you some new ideas, some inspiration for how you and your colleagues can make that happen. So do have a look at our website. We'll be hearing a little more at the end about the excellent support that LGA offer in this space as well. And do get in touch if you'd like to discuss anything further that I've mentioned. Thanks very much.
Thank you very much, Catherine. I'm now delighted to hand over to Kate Kennelly, who's going to talk more about what they've been doing in Cornwall. So thank you, Kate.
Thank you and good afternoon. Really great to be here at this webinar. So I've been asked to talk a little bit about the Cornwall Development and Decision Wheel, which has been the manner within which that we have embedded health in all policies in Cornwall, but also embedded other requirements that face us as local government leaders, whether that's about our climate obligations or about our equality obligations or what we're wanting to do about child poverty, into a single tool that seeks to get the right balance between people, place and pounds. So if we could move on to my next slide, first of all. We developed this tool as an initial response to our climate emergency and having been inspired by the work that Kate Rayworth did on donut economics. Cornwall is a place that has been about rebalancing its economy, moving away from the visitor economy into a more diverse economy, but doing it in a way that is about making sure that people aren't left behind, because Cornwall benefited from significant amounts of European structural funding as a less developed region of the United Kingdom. And so it became very important that when we were talking about growth, it was good growth that was environmentally sustainable, made sure that people weren't left behind, and it helped shift our population into one that was going to be sustainable. And donut economics really spoke to us around that benefit of how you can look at that triple bottom line approach. So taking that, we then wanted to practically apply it to a place, and we developed this decision wheel, which has been created in-house using existing Microsoft platforms to ask a series of questions on the environmental elements of any decision, on the people-related elements of any decision, and then incorporated our equality impact assessment, then looking at the equality and inclusion elements of any decision. So the environmental ring assesses the impacts on health, housing, connectivity, food access, air quality. The equality and inclusion is that differential impact on our protected groups and communities. We've explicitly incorporated health-related questions into pre-populated questions that sit in our IS tool that our public health colleagues have been involved in helping shape. So, for example, health is obviously covering both physical and mental health needs. It covers implications from health education to access to medical facilities. So in our decision wheels, it will include things like, well, will this policy help improve resident access to health services via infrastructure, funding, programs, or staffing? Will it help promote access to healthy food choices? Will it, for example, aid with access to natural spaces or improve the standard of existing homes? Will it help address fuel poverty through access to efficient heating? And each of our questions are pre-populated according to key issues that have come out from our health needs assessments, our insights, some of the tools that Catherine referred to from the Health Foundation, giving us that Cornwall-specific information about what matters most to us. So if we could move on to the next slide, please. So what's been the impact now of having the Cornwall decision and development wheel? Well, we've been operationalizing this now for over 4 years. We've got hundreds of decision tools that have been completed. The way, though, that it's changed us as an organisation is that it has made sure that our triple bottom line approach does really inform our decisions, and that our decisions are informed by evidence, because the colours that you see on the decision wheels are informed by the answers that are given to these pre-populated questions that have the evidence base that sits behind them. It means that both members and officers have to consider the broadest impacts of their proposals, which include health, housing, connectivity as standard practice. It also means that it requires cross-departmental working and really helps to break away from siloed thinking, enabling us to see the potential impacts of a decision and key areas for debate and mitigation early on. I think that for our partners, it's brought greater transparency and accountability into our decision making. And we've also been able to update the way within which that our tool works quickly to reflect any policy changes, such as we've recently seen with the Supreme Court ruling. It's about trying to make things easier for the colleagues working in the council to draw the connections and the impact of their decisions. We've had a lot of positive feedback from our peers and partners, and we've demonstrated the tool to over 100 local authorities and organisations, which hopefully has been beneficial to them, but it's certainly been beneficial to us in helping us to continue, refine and improve. So if I could move on to my last slide, please. So we're asked to reflect on what's worked, what's maybe got in the way. I think that the enablers that have made this happen is the technology. We've used our Microsoft suite to build the tool, but also to link it through to our raft of Power BI dashboards, insight tools that are available to us more than ever as practitioners in our work, but a way of integrating that so that becomes meaningful insight and intelligence. Our decision wheel has the buy-in from the highest level. I'm here today to speak to you as the Chief Executive of the Council. This is something that is fundamental to us as an organisation and our mission to try and balance the scales of Cornwall PLC so that we remain a healthy and sustainable place into the future. And it's had that wide support from partners in the public. We collaborated with Exeter University to help us think about the application of this policy work that Kate Rayworth did to a local government context. But there are some barriers. It's a great tool. We've got hundreds of Cornwall decision wheels, but there's still places that we have to keep working hard to make sure that people are thinking about this early enough on. And that's why that senior level sponsorship is really important. And because it's very Cornwall specific, it pre-populates questions, and the methodology based on our place might not mean it's as easily as translatable as perhaps we thought it might be to others. But you can find out more, and we'll send the slides around on our decision wheel through the video and also through some of the web links where you can find out the differences made, and we'll be very happy to continue to share our learning with colleagues. Thanks.
Thank you, Kate. That was fascinating to hear that, and hopefully we'll get lots of questions coming in for you about your wheel there. That would be fabulous. So just a reminder to everyone, post your questions in the Q&A and give them a like if you want them to be answered. So next person I'd like to bring in is Sonia Milne, and Sonia is going to tell us about how shaping capital infrastructure has been used to improve health in Glasgow City region. So Sonia, over to you. Thank you.
Thanks, Louise, and hi everyone. As Louise has already said, I'm going to briefly talk to you about the HiAP, which stands for Capital Investment Health Impact Assessment Resources. Quite a mouthful, which is why we're calling it HiAP for short. As the example before from Cornwall, this is an example of health in all policies approach in Glasgow City region, specifically aligned with the tried and tested health impact assessment process. Next slide, please. As before, I will briefly outline the approach taken to develop the resources, what they include, how they are proposed to be used, noting some impact from this process. Bearing in mind we've just started to roll it out, it's just been developed. And then finally, I will conclude with a short overview of some of the enablers and barriers, not just for the development of our approach, but, and perhaps more importantly, for the continued and meaningful implementation of HiAP and ensuring its full impact or potential impact is realised. Next slide, please. The work of the HiAP resources, as we've already heard from Catherine, was funded by the Health Foundation under the Economies for Healthier Lives programme and resulted from a partnership between Glasgow City Region, Public Health Scotland, Glasgow Centre for Population and Health, the Scottish Community Development Centre, and of course the 8 local authorities in Glasgow City Region. The resources were developed through an iterative process following the appreciative inquiry model, similar to the Design Council's Double Diamond approach. This meant extensive research and engagement with national, local and regional partners, both with expertise in public health, but also leading on or involved in capital infrastructure planning and delivery. The project community panel were a key part of this engagement, and also our active academic partner who supported a formative and reflexive evaluation throughout the duration of the project. The key messages emerging from this iterative process and this engagement were that, and this will be not a surprise, not to anyone in this virtual room, that health and equity were recognised as important issues across multiple sectors, from housing to transport, but also that, and conversely, that there was a significant competing demand and pressure on project teams' time, knowledge and capacity. So the main ask from local authorities, who are the intended users of this set of resources or toolkit, was for the resources to be online based, for them to enable easy access to relevant data in one place and relevant health and inequalities information, while also providing them with support for project teams to fulfil their existing duties, namely equalities impact assessments, Fair Scotland duty, public sector equalities duty, and various environmental impact assessments that are usually required as part of sectoral capital projects, and to support them to undertake these and comply with these more meaningfully and holistically. So in this context, it was agreed that using learning from a health in all policies approach with a proven track record, such as health impact assessment, would be most effective, as it would allow for screening of multiple impacts on the determinants of health, but also consideration for different population groups and environmental issues as well, that could then be fed into existing processes, such as the sort of business case development process in terms of risk management and benefits realization, but also responding and considering equalities duties more meaningfully, without creating a potentially perceived burden to our local authorities teams, particularly those involved in project management. So HiAP then emerged as a set of online resources, which you can see on the screen, hopefully just a screenshot of the webpage, and we can share a link to that later in the chat as well, providing guidance about health and equity, supported by a practical process of screening for health impacts of a proposed infrastructure project or programme, and then informing and guiding teams to inform the business case development by specifically helping to include risks and benefits considerations throughout that process, particularly at strategic business case, but really can be used at any stage of that process. The HiAP then includes access to relevant population data also in one place, not new data, but existing data brought into the one place by Public Health Scotland, who have a metadata catalogue, which we were able to link into this toolkit, but also knowledge on health inequalities, in addition to training on health inequalities more broadly, how they link with capital programmes, and a practical use of HiAP resources to better consider all of these issues in practical terms when developing a business case, and the sort of practical element also of undertaking that stakeholder workshop to allow that early screening for health and equity impacts of a given proposed project. Next slide, please. So as before, I will just briefly talk about some of the early impacts emerging. And as I also said, that the project was developed this year, sort of ended this spring, and we've had a number of pilot projects, 6 across the city region, and 2 or 3 regional projects, and 3 local authority-based capital projects. And through the engagement with those project teams and a pilot project evaluation, we were able to sort of start to identify some early impacts, such as the embedding of HiAP, for example, in the Glasgow City Region Project Management Office governance and business case appraisal processes. So HiAP is now included in the project management toolkit and is part of the questions that are asked of our local authorities who submit business cases for approval, to evidence consideration of health and equity impacts of their proposal and how these are proposed to be addressed. Another early impact has been from engagement with our projects, from a project of national significance, such as the Clyde Metro, who undertook the HiAP process, then leading to the team committing to a full health impact assessment, which has been commissioned, but also committing to having health inequity as a key work stream in the development of the case for investment. Now having led to the team recruiting a public health expert to integrate the team and to really help to include health in their sort of case for investment rather than only your traditional transport planning and economics perspectives. Other early impacts include the comments from our teams to say that they found the process of having different partners in the room discussing health inequity, but also discussing their project proposals quite refreshing and positive. They've reported to us that it's helped to build and strengthen relationships with their local partners, including our 2 health boards who have now committed to supporting this health and equity screening process, attending the workshops and supporting local authorities with that public health expertise. I'll finally say that one of our projects who've undertaken the HiAP screening process earlier this year, the electric vehicle charging infrastructure, have now begun to include health and equity questions in their procurement exercise and their tender processes for their contractor who will come and construct their charging infrastructure, but also to their local authorities who will then operate that going forwards. Next slide, please. I will conclude with some sort of enabling factors and challenges we have experienced throughout the development of the process, but also that we see as potentially being key as we move forward with the full implementation of the HiAP. Some of the enables I've already alluded to earlier on, but key to this process and to its success was really that strategic leadership and buy-in from very senior level at Glasgow City Region, from the Regional Economic Partnership and the sort of vision of the Regional Economic Strategy around building a more inclusive and climate resilient city region, having the chief executives from all local authorities and the 2 health boards committed to a collective approach to building a more inclusive economy was key to setting the scene and to continue to develop those relationships, particularly with Public Health Scotland and Glasgow Centre for Population and Health, who were key partners in this process, and the 2 health boards, of course. Another enabler, which I've alluded to, was also Glasgow City Region Project Management Office having the impetus and the power to include questions and to manage the development and appraise business cases and being able to add health and health impact, making health impact screening as a recommended part of the business case development, really enabling and supporting project teams to consider health, but also requiring them to evidence that approach, offering them training for health and equity alongside the Green Book training that is offered annually to local authorities. Finally, and also importantly, was the approach of the Scottish Government around their population health framework, which takes a preventative approach to health inequalities and includes health in all policies as a key pillar of this framework, setting the scene for the commitments of our local authorities and the city region alongside the rest of Scotland to really get behind that preventative approach and having the HiAP as a means to demonstrate that, particularly around capital investment projects. In terms of some of the challenges we've experienced, I've outlined the sort of differences in culture between economic development and public health, particularly around the pace of decision making that's required in the business case development process and the sort of delivery of capital projects in terms of delivering infrastructure on time, on budget, and the pressure to have evidence that's just good enough to deliver something that we have some confidence in and that will be here for many decades to come, versus the time that it actually takes public health experts and professionals to develop credible, robust evidence that can inform decision making. So this is something that we're working on and continue to work on with our public health colleagues across the health boards, but also Public Health Scotland, to improve on and to use existing evidence to enable that fast decision making to include at least the latest information and evidence to ensure that what we're building now will meet the needs of our local communities, particularly those most vulnerable. And finally, to conclude, this won't be a surprise to any of you, another of the challenges we've experienced is that limited resources in the system, both the public health system, but also economic development with multiple challenges, multiple demands and pressures on time and lack of knowledge or resources or even time. And so that's something we continue to work with our NHS board colleagues in particular who have committed to supporting our local authorities and lending some of that public health resource in the system, potentially something we need to continue to work on as part of that strategic approach to inclusive economy in the city region, and making the case to that collaborative approach to potentially bring in more resources from different organisations to support us jointly to reach the vision set out in the regional economic strategy for an inclusive and climate resilient economy in 2030 and beyond. And with that, I will conclude. Apologies, I may have run over time a little bit.
Thank you, Sonia. And I've seen some questions coming in for you already, so we'll get back to you after we've heard from Michael. So our next speaker is Michael Chang, who's going to talk about understanding how local authorities, local plans and spatial planning can improve health. So Michael, over to you.
Thank you and good afternoon, everyone. So I've been asked to speak to you about a particular tool or lever available to local government to deliver and implement health and health policies, and that's about local planning or the planning system. Next slide, please. Thank you. So the planning system, at least in the UK context, does support the opportunity to deliver health net gain across social, economic, and environmental objectives, and this does include supporting strong and healthy communities and healthy places as well. And in order to understand how health is driven and influenced by the environment, we kind of have to look at the planning system and local plans created by local authorities to see how they are articulating health requirements and health narratives in their policies, because ultimately land use decisions are based on the local plan and nothing else. So as part of my research, I've looked at all local plans. This is for England only for now. About 344 local plans of the 314 odd local authorities with planning functions. And I won't go through all the maps here for you, but primarily the matrix used was to look at the local plan wording and see whether they do exist on certain topics around the building blocks for health, for example, air pollution, green space provision, access to food, etc., and healthy homes, but also whether health was part of that policy wording. So in general, that map in the center was the outcome of a baseline understanding of where local plans are currently sitting in terms of having health in their local plans. So about 37% of councils in England have a particular health and wellbeing policy or healthy places policy in their local plans. The maps on the side are primarily to give you a visualization of how health and all policies are being, if you like, addressed in these local plans. And they range from quite good, if you like, representation of health and air pollution policies, noise pollution policies, and green space policies, to fairly limited, I would say, presentation of health and policies around the urban heat island, for example, overheating. So that shows you the potential to improve local plans going forward with local authorities doing their reviews to really embed health across these different policy areas, but also others that the local authorities may be deemed important for their local areas. Next slide, please. Thank you. So one of the things that I look at is the local plan, because the local plan is really a legal determinant of health, as the Lancet Commission coined a few years ago. And because many decisions that we make in this country are based on the local plan, you can argue that a lot of the health issues that we are facing now, or maybe in the future, we've allowed it to happen. We planned for it, we've legislated for it, we've subsidized those kind of interventions. And therefore, the planning system, at least local planning decisions, were the problem, we can become a solution. So as part of my research, the outcome of the research, It helped inform a what good looks like document with the ADPH here. That's UK-wide, it's not just England-based. And that brought out the 8 ingredients of what a good local planning for health system could look like. That begins with building capacity all the way down to developing health and policies, and also about learning, reflecting, and also measuring achievements. Because of the fact that planning system is a system, we have to think about the local plan and everything else you do with the local plan as a system. So you need capacity to deliver policies and develop policies. You need capacity to implement policies, but you also need research and evaluation to understand how your policies have made an impact. So my research essentially graded councils' local plans on a scale, and it's not a league table, but one of the key good examples of local plans I have found was Milton Keynes. They have a very strong evidence-based paper named People-Friendly and Healthy Places. They're informing their local plan review currently. They have capacity around planning for healthy places posts in the local authority that was recently evaluated and found a positive impact on the process and the outcomes for health in Milton Keynes. And ultimately, their local plans have a range of policies that address the building blocks for health, and therefore is deemed a really good quality local plan. And Milton Keynes was featured in the CMO's Health and Cities report last year as well. So I'll urge you to look at both the ADPH, what good looks like documents, as well as key councils that we reference as good practice in the ADPH document. Next slide, please. Thank you. So my final slide, I think it's really important to acknowledge the barriers that are preventing some councils from doing good planning for health or using the local plans to maximum effect to deliver health outcomes in the local populations. We've all known that health and environment in place are very much linked. The evidence is very clear. The evidence is stronger than it has ever been. But as that quote showed, that we've spoken about this for a long time, but few people really give this issue their undivided attention. So therefore, one of the key things that I'm looking for is the barriers that are preventing councils from doing so, and they're there for you to see. So we need to clarify health in national policy. What does health requirements mean in national policy for councils to take action? We need to embrace complexity in the planmaking process. It's a very complex system. It's a legal system, and therefore it's very complicated for people to get their head around. But we have to make sure that we embed health in those planning policies, so decisions are based on health in local plans. We have to apply translational evidence informing these local plans, so they are based on the health needs of the population and the health priorities that the health and wellbeing boards have agreed to take forward in the next 5 years. We have to reduce delays in the decision-making process. We have to leverage positive politics and planning. We have to resource local government and also invest in capability and skills. And many of these barriers are actually now becoming opportunities because local authorities are now recruiting, for example, healthy places posts to help plug the skills gap around healthy placemaking locally. And also many councils are bringing forward policies in the local plans. They are health promoting and also promoting health impact assessments in their policies as well. Finally, to say there are many resources produced by different organisations in England, Scotland, and Wales. They guide councils to build health into their policies. The Town and Country Planning Association published a guide earlier this year looking at health in local plans. Public Health Wales, with the Health Wales HI support units, have published guidance on health in local development plans, and Public Health Scotland have published health in local plans as well in the last few years. So I would urge you to look at those guidance and help inform your future reviews of your local plan and ensure that we build health into those local plans and improve population health. Thank you.
Thank you, Michael. That was really fascinating, actually. I look forward to looking at the work that you've done in more detail. We've now got opportunity to ask some questions, but I just wanted to start off on one. I actually did some training myself this morning, and I went on a data masterclass, and we talked about the importance of data. So a question for all of you, and I'll start off with Catherine. How can we better understand the impact that health in all policy approaches are actually having on the on our population? So in terms of that sort of evidence, what more do you think we could be doing to understand the impacts better? So Catherine, if I start with you for that, please.
Apologies, just struggling to come off mute. Yeah, absolutely. I mean, it feels really, really important, that kind of building in understanding of the difference this is making from the outset. And I guess I'd say a couple of things. I think one is that it's important to measure both processes and outcomes. So I think understanding, we've heard today about some of those points about how people are feeling about, is it different? Does it feel different? Are we building and sustaining different types of relationships? And I think understanding whether those things are happening, and then that explains whether or not the outcomes are changing. So I think understanding both process and outcomes is important. I think that other point about timescales is quite important. So understanding that shifting health outcomes can take a long time, and understanding what the kind of intermediate outcomes that enable us to show that progress is being made. I think that's important kind of politically, presentationally, to be able to show that there are some short-term wins, but being able to understand the kind of theory of change that shows that the intermediate outcomes you're achieving are getting to the final outcomes that we want to see. And then I suppose finally, I think it's not about doing a kind of evaluation at one point in time. It's about embedding learning and iterative learning and evaluation into the work as you go. So I think that's really quite important. And I would just flag that we've recently worked with the Growth and Reform Network on a piece of work, which I can put in the chat, which is looking at how over time, both nationally and internationally, local areas have managed to embed thinking about health within thinking about other policy areas. And actually that shows that actually these points about time, about understanding processes and outcomes, and understanding some of the intermediate outcomes are really important. But that is an interesting piece of work, and does show that the value of health in all policies, and gives some really solid evidence of where health has shifted through work on other areas.
Okay, thank you. Kate, from your perspective, anything to learn from Cornwall?
Well, I thought, great answer, Catherine. Agree with all of those points. I suppose I think that how can we better understand impacts? Well, I think we have to stay continually curious around this. And I'm probably of a view that you don't necessarily get your answers from impact assessments, is that it enables you to ask better questions. And I think that there's something around, actually, there's so much interplay of lots and lots of different factors that could have either a positive or a negative impact on an intention. And Milton Keynes, Michael, I mean, when they were building it in the 1960s, I mean, a vision of the most walkable, livable city. And it had unintended consequences, some great, some bad, but the intention behind there in the policy, as strong then as it is now. But things change, society changes. So we've got to stay curious. I think we've got to be absolutely multidisciplinary in terms of how we look at this, because actually a lot of the issues are two sides of the same coin. And it takes generational impacts, some of these changes. So that theory of change, your lead and your lag indicators, really important, and have the backing of some of your academic partners behind you, so that you can build, either that counterfactual or some of that evidence base to help you really select the right measures as you go.
Thank you, Kate. Sonia.
Thank you. Thanks, Liz. I don't have an awful lot to add to what's already been said by Kate and Catherine. I agree with all of that, and particularly in terms of the HiAP and the sort of health impact assessment process. And as Kate said, these processes allow us to ask better questions and hopefully influence better decisions. In our case, better investment decisions, better infrastructure, that in the longer term, in 20, 30, 40 years to come, we will be able to evidence their impact amongst other policy decisions that are made in our population health. But yes, I think for us as well, we were very mindful in developing the HiAP, in having those interim outcomes, those interim indicators that would allow us to measure impact without setting our project teams up to fail. If we're asking them to demonstrate evidence in terms of population health, how could they do that in terms of their limited influence. So that multidisciplinary approach, and that approach in the city region as an example, because it's what I'm more familiar with, of working across multiple partners, Scottish governments, the local authorities, the health boards, Public Health Scotland, Scottish Enterprise, bringing everybody together from their different disciplines and having health as that key goal, I think would be key to start to inform better evidence, but also better measures and metrics to help us evidence impact on population health in the longer term.
Thank you very much. And Michael, anything else to add from your perspective?
About 2 points. I think one of the things that I found really interesting, definitely when I embarked on my research into local plans, even though it can be quite technical, is that people don't quite understand what they have currently, or at least make the use of the resources that they can have to deliver on health and health policies. And if you look at local plans, at least, many councils just don't know what they have in those policies. But by having a baseline understanding, you can really improve on things going forward. Without that baseline understanding, you really can't move forward. You're always thinking about what you need to be doing without really understanding what you have currently. And that kind of brings my second point and last point about learning from the past. And because many of the things that we have and are currently doing, they're not really new things. We've done them before. But for some reason, we've kind of forgotten that we've done them before, and therefore we keep reinventing the wheel. It's not necessarily a bad thing. It just means that we're not learning lessons and the barriers and the threats, if you like, that those people face when they were doing those initiatives a few years back, and therefore learning lessons is really quite important. One final thing to add is I think the planning system, at least in this context, is a delivery tool. People think the planning system, planners make up rules and priorities for their areas for the next 15, 20 years. But we don't. We are a delivery mechanism for local authorities or for regional authorities, and therefore understanding its potential is important. It can't address everything around the health agenda, but used properly and understood properly, it can be quite powerful for local authorities.
That's brilliant. And actually, we're at a point now with all these new towns that are going to be coming online. And I don't know if there's anybody on the call today who's got a new town that's going to be built in their area. This is a great opportunity, isn't it, to learn lessons from the past, to look at all the work that you've been doing and to do something really special. So I look forward to hearing in the future about how they're developed. Okay, so we're going to go on to some questions now from the audience. I've got one first for Kate about your decision-making tool. And the question is, does the decision wheel include a qualitative local knowledge? Does the decision wheel include qualitative local knowledge from residents or the voluntary sector? And if so, how did you achieve this?
Yeah, thank you. So I referenced in my presentation that the decision tool requires people filling it out to ask a variety of different kind of questions, and then it's kind of got pre-populated according to what level of impact dependent on the answer that they give. The data sources that the tool draws from are a mix of both quantitative and qualitative data sources. So for example, local knowledge from our residents, that will be drawn from our resident survey intelligence information, or we might be bringing through, for example, our analysis of complaints into the mix in terms of actually some of those sources of qualitative data. Every 5 years, we produce what we refer to as the Cornwall We Know, a detailed cross-Cornwall insights tool, drawing on a variety of different data sets to inform what we're doing, and that can be added to all of the time. So, for instance, our Director of Public Health report this year has been on child poverty, but written from the perspective of babies, children, and young people, which was a very different way of building that report and gaining that lived experience through into our work, which is now in the Cornwall We Know, which is then informing the tool. So it's a variety of different methods, but the tool is reliant on good intelligence, and that comes from a variety of places.
And just a follow up from that, obviously the quality of the completion is based on the people that are actually doing it. And there's a question there around compliance and quality from the people who've actually been using the decision wheel? Any sort of lessons learned from that?
Yeah, two things. I mean, first of all, this is a hearts and minds piece. So this is culturally something that I see as mission critical to us as an organisation, to why we exist as a place, and the values, our fair values that we have. So, process requires people to believe in it. But then when you've got a process, is that you need to know it's being adhered to. Our decision wheel is embedded in all formal council decisions that are linked to policies, strategies, financial decisions, our business plan. So it is subject to quality assurance through our normal report clearance processes. And each wheel is subject to peer review from a team of colleagues within the council trained up in the use of the decision wheel. Thanks, Louise.
Thank you. And Sonia, I've got one for you here about, so what training or publicity or communications did you use or try to use to help embed the tools, and which seemed to have the best result?
Thanks, Louise. So in terms of the approach we took in the City region to embed the tool and to have the training rolled out. As I alluded to in my presentation, we have a project management office in Glasgow City region with the responsibility to manage and appraise business cases and ultimately recommend projects for approval for the sort of two key governance bodies in the city region, the cabinet, where all elected members or relevant elected members sit from each local authority, and our chief executives group. So as part of that process, there is a governance process, the project management toolkit, which guides local authorities to put together their business cases. And one key way to embed this process has been to include HiAP as part of that guidance, but also the appraisal of what comes in. So teams know that this is required, and therefore they get in touch with us to access the training, which the training was developed by Public Health Scotland. And again, we engaged throughout the process, this iterative process. We tested and refined the toolkit as it stands, and that includes training. So we had a training a pilot training session to really try and understand what project teams already knew, what they needed, what would they find useful. So based on that pilot training session, Public Health Scotland then went away and put together a training package in collaboration with our academic partners, Glasgow Centre for Population and Health. So I suppose a combination of embedding HiAP as part of our business case governance process, but also we have a HiAP Champions Network who have helped us to develop the HiAP and are now tasked with supporting its implementation and championing it, promoting it within their own remits, local authorities, public health, voluntary sector. So they have been key to help us to promote it to their colleagues, but through the city region communication channels and our engagement with all 8 local authorities, that's how we've promoted the training, which they helped shape and develop. So it wasn't too challenging to get them to engage in that, and they've all attended training, which we've committed to offering on an annual basis. I don't know if that answers the full question or if I've forgotten.
No, I think it does. I mean, the question went on to ask about impact assessment, and I think you probably answered that in your previous answer where we talked about impact assessment. But I think you probably did. So thank you for that, Sonia. There's an interesting question that's come in, which I see in 2 parts. And Michael, I'm going to ask you to answer the first part, which is it's quite disheartening how many local authorities don't have health in their local plans. And can you say anything about why it's up to every local authority to develop their own plans? So if you could come back on that, Michael, and then Catherine, I was going to ask you, why isn't there more national policy on this, and what can we all do to try and encourage that national policy?
Thank you. I think I should say that the research doesn't actually basically what I'm trying to say is that just having a policy in the local plan doesn't automatically mean that you'll have a healthier population. But as I said earlier, much of the decisions made by local authority planners and others are made based on the local plan. The reason why it's based on local authorities developing those plans, not national government, because obviously local authorities know their populations more and better, and therefore their priorities are reflected in the local plans rather than national government saying we'll create one with every single local authority. So I think that's a kind of first thing to say. The second thing to say is I think definitely in terms of health needs and health priorities, the local government structures already have a process of being involved in the planning system. And actually national policy already requires planning policies to consider and take into account local health needs and support the delivery of health strategies like the health and wellbeing strategy, like a state strategy. So therefore, it is really down to local authorities to think about what works for them and what the priorities are for the next 15, 20 years. To finish off really on the points about why councils don't have health in their local plans, and actually, if you look at the maps closely, many of them actually do have health across the different policy areas, but just not all of them all at the same time. And I think someone mentioned earlier in terms of being flexible and resilient to future changes. Local plans are reviewed every 5 years, and therefore there may be things that we can't foresee now. They may be coming up in 5 years' time, and therefore policies can evolve and adapt to those future challenges. And that's how local plans should work, rather than being an inflexible document for the next 15, 20 years.
Thank you, Michael. And Catherine, what more can we do to, why isn't there any national policy, and what more do we need to do?
Well, I was going to make a bit more of a general point, really, that this is a great conversation about high health and all policies at local government level. But there is an irony that we don't always see that at national level, and the Department of Health, MHCLG, etc., working in silos, I think is a real problem when we talk about enablers and barriers to health and all policies at a macro level. I think the way as many have said before me, the way that Whitehall works doesn't always enable health and all policies at a local level. I mean, I think the Health Mission felt like it was a potential opportunity with its focus on addressing the wider determinants of health and reducing gaps in life expectancy at regional level. But it feels like the focus has moved away from that, and understandably to an extent, focusing some of the pressing challenges around the NHS. But I do think continuing to focus on what is the government's view on how we improve health, not just through the NHS, but through the building blocks of health, is something that the Health Foundation, we absolutely continue to call for a whole of government strategy to address health. And I think a lot of these things would then fall from that if health was more explicitly embedded. And I think there's another range of other things that national government could do in that kind of enabling space. I mean, I think there's clearly something about resourcing, there's something about the financing, but also the staffing that would enable some of this to really be embedded and move away from some of the firefighting and actually really focus on some of these issues. I think that's really important. I think incentives and culture, as we've picked up, are important. And again, national government has a role to set some of the frameworks there. But I do think, as Michael says, there is a lot of stuff that is happening at local level, despite the fact that that national framework isn't always there, always vaguer than we might like it. So I think that feels quite positive. So yeah, it's not ideal, but I do think there's more that it could be done at national level. But yeah, I'll leave it there, Louise.
Yeah, thank you for that, Catherine. I did notice a question about cross-party support and what more could local authorities be doing. And just from a local government association point of view, I've actually identified as health inequalities of one of my areas of focus for this year. So all our policy committees, and there might be some people who sit on them who are attending today, that health inequalities is a golden thread that's running throughout those. So if you're on one of the policy committees that's looking at local plans, and this is something that you could actually pick up with next time you're attending one of the committee meetings. Okay, so I've got a question here which I'm going to ask for all of you, and it's about learning, and it's any top tips discovered for light touch wellbeing impact evaluation for people who touch services. So I think, Kate, I will come back to you for this one, please.
Sorry, Louise, just lost my mute button there. Yeah, light touch. Well, I do think that this, I'm really lucky being in a unitary council, of having our public health team kind of working alongside our colleagues. And I think one of the things that's made a real difference has been having lead public health consultants working with each of our leadership teams, building those relationships, taking that evidence base, bringing it into conversations, into discussions. And I do think use your public health colleagues to really support this work and draw on their insight and their intelligence sort of skills that they have, to enable us to ask the right questions. So yeah, I think that's probably where I'd start, Louise.
Okay, thank you. Sonia.
Sorry, my mute button was a bit sticky. I suppose that in Scotland we have the sort of wellbeing economy toolkit, which was and a wellbeing economy monitor published by the Scottish Government, which supports local authority and regional activity to understand impacts and to monitor decision making and impacts on human, natural, and other relevant capitals. One of my colleagues also helpfully suggested that there is an existing tool, which is the Warwick Edinburgh Mental Wellbeing Scale, usually called WEMS, which could be one way of assessing any change in mental wellbeing, and that is evidence-based in this context. I don't know if that's what Sue was asking, and if that helps. I'm happy to clarify anything if not.
That's great. Thank you, Sonia. Michael.
Thank you. I'm not sure how the question directly relates to the planning system, apart from asking for potentially the use of impact assessments. But my slide, the second slide, showed there are many points in the system where people can get involved in both policy development and influencing decisions as well. And that is about looking for points, opportunities to take action. So rather than looking for always the one thing that actually may not come in the next 5-10 years, sometimes the lower hanging fruits are possibly the most effective in the short term. And at the same time, you build capacity to deal with the bigger issues like national policy changes. So the light touch approach is really not about doing anything additional, just doing things differently, to find the right points in time and in the system to leverage maximum impact with minimum effort. And that can be done if you scope out potentially your role in the system and which parts of the system you want to influence to build health into local plans. That could be about capacity, that could be about monitoring evaluation, influencing the DPH annual report, as you mentioned earlier. The Leeds City Council DPH report a few years ago was based on the health and the built natural environment, and that won the ADPH awards, and that raised the profile, at least in that part of the country, around health and the built natural environment. So finding other points in the system where it can make the most impact is possibly the most effective thing they can do in the short term.
Thank you, Michael. And Catherine?
Yes, I'd agree with everything that's been said. And just to build on some of that, I think there's something really important about building a shared language across an authority, which I think I referenced our frameworks toolkit earlier, but we've seen that ability to work across different parts of the council, as Kate says, drawing on public health expertise, but also working with other heads of service and other teams, and having a shared understanding of, as Michael says, points of impact, but also, what are those building blocks and what levers do we have to influence them? So I think it's that kind of, common understanding of what the mission is, but also the co-benefits between working to reduce health inequalities, but also achieve other objectives that the council is working towards, which again is what Kate's been talking about through the Cornwall approach.
Excellent. And what I thought I'd ask you all is, if there's somebody who's on the call today and is just sort of at the beginning of this journey around health in all policies, what's the one thing that you would recommend to really kickstart the process when they go off the call and they're thinking about, right, what do I need to do next? So Catherine, because do you want to start off with that, and then I'll come to the others?
Well, at risk of repeating myself, I do think it is that building a shared understanding of what can we do? Well, what is the problem and what can we do? And how are we going to join that up as a single endeavour, whether it's through the Cornwall model or another model, but actually showing the interdependencies, and that addressing health inequalities isn't an extra nice to have, it's fundamental to the delivery of everything else. So I think having some model that articulates that and embeds health is really important, and the building blocks language is a way of doing that.
Excellent, thank you. Sonia?
Thanks, Louise. I agree with what Catherine said, and I suppose quite an obvious point is to ensure that sort of senior level buy-in and that strategic buy-in, of all the key players, to then help to identify those common goals, as Catherine was saying, in terms of what do we want to achieve, what do our organisations individually want to achieve in the city region, in the case of the city region, and what do we as a region where do we want to get to, be it community wealth building, be it inclusive economy, be it healthy working lives. What do we collectively agree we want to get to, and how can we use health in all policies as a means to that end rather than an additional layer or an additional burden, but also understanding what it is that's already being done well, what's the best of what there is, and strengthening and building on that to achieve our collective goals, I would say.
Thank you, Sonia. Kate?
Yeah, so I would say somebody at the start of their health in all policies approach, really understand your local situation, make sure that you've got the local data and the stories to show how health outcomes in your area are shaped by the policies that you're then wanting to try and change, whether that's transport, housing, education. So make sure you know yourself, that you've got the evidence base, and then really adopt that health in all policies approach to then improvement around using the frame of prevent, reduce, delay, so that you can then have a framework through which that you can ask the right questions and draw on that evidence base. And I'd finally say, make this something bigger than your own team or your own directorate or even your own organization. It works best when it's that shared objective for the whole public, private, community and voluntary sector, and bring people in to explore how to go about doing this in your place.
Thank you, Kate. And Michael?
Thank you. And just to build on many of the points that were already raised, I think doing a stock take, I think if you look at what's happening locally, because just because you're new doesn't mean the agenda is new for the local area. And therefore, you don't want to rush into doing things. Doing a stock take of what's happening across the local authority area, different systems, different strategies already in place, and you can see how mature the organization is or should be, and where you fit in the system. I think that's where you should start. Thank you.
Thank you. And questions come up around local government reorganisation, the move to more strategic authorities. So what should we all be doing now whilst we go through that? Because there is substantial change going on in the structure of local governments. What opportunities does that present, do you think, for health in all policies? And I'll come to you first, Michael, particularly around new local plans that are going to be coming out.
Well, I mean, I think for now, in the meantime, nothing will change. And actually, most of the policy requirements from national government will already be in place. So therefore, again, just looking at the ingredients, what good healthy planning looks like from the ADPH document, work your way through those ingredients will be quite a useful thing to do. Many local authorities already have policies in place, and so therefore, wouldn't be a need to if you like, reinvent new policies and just seeing how those policies apply across the unitary or the strategic authorities. I don't have all the answers. I think, Catherine, the Health Foundation is funding a piece of work looking at this particular area, and look out for that piece of guidance. Finally, to say, I think capacity is something that we need to think about, at least for unitary or a county that's becoming a unitary. Capacity will be a key issue, because the fact that you're covering so much geography, you need people with the right expertise to be dealing with the right issues at the right time. And so you're basically investing to save, because you're investing in capacity to save on prevention, healthcare costs in the future. So see in that light, as well as looking at all the other policy interventions.
Thank you, Michael. And Kate, Cornwall's been through local government reorganisation, and maybe devolution will be coming to you one day. So just wondered if there's any learning you could, or tips you could give to areas that would be going through LGR over the coming months and years.
Yeah, I would certainly say hold the faith. It will be worth it. There is no way that Cornwall Council would go back to a single county council and 6 district councils. The benefit of coming together to serve our community as an integrated unitary authority has delivered many, many benefits. But you need to also recognise those strengths that are there with smaller footprint local authorities, district councils, about having that focus in on neighbourhoods. So I think we've got a real coming together of both kind of health policy and also where local government's going, a strong focus on our neighbourhoods and on our places, enabled by a strategic authority that's got the capability and the capacity to be able to build that data and that insight and what works, but through local delivery. And it takes a while to build that maturity of some of those ways of working, but both are equally as valid. And I would say to colleagues going through it, don't underestimate what you need to keep in that strategic core in order to be able to go after those benefits and really empower your front line to make the changes that are needed on the ground. And health in all policies could be a really good bridge between those two areas of activity.
That's a really good answer. Thank you for that. Sonia, I think things are slightly different in Scotland, but I don't know if you've got anything else you could add to that.
Thanks, Louise. Things are different in Scotland, and as you all know, Glasgow City Region is not a combined authority at this stage. It's all 8 local authorities come together. They came together originally as part of the city deal, but there is an aspiration for a sort of devolution to further down the road. We don't know what that will look like, but there is an aspiration to build on the strengths that already exist and that have formed through the city deal and through this wider regional approach to economic development, to community wealth building, to going beyond the infrastructure investment and using that investment to scale up the footprint within the city region. So I would probably say we would learn from those in England who have been through this process, about certainly building on the strength of relationships which already exist, and the work that's happening at regional level, national level, at Scottish Government level in terms of that population health framework I alluded to earlier, and the sort of foundations it sets in terms of health and in all policies as a pillar, and building on best practice that we know exists across our local authorities, across our health and social care partnerships, and learning from others further south of the border as well. So apologies, it's probably a non-answer because we're a bit further behind in that process, but really useful to hear from others.
Yeah, thank you, Sonia. It wasn't a non-answer, it's a very nice answer. Catherine.
I was just going to make a point about the opportunity posed by the health duty that it will be placed on strategic authorities in the bill, and I think that focus on health through the health duty, but also health wellbeing and public service reform being an area of core competence for strategic authorities should raise the profile, which, as Kate says, then drawing on the kind of convening strategic powers of the strategic authorities in a way that should not duplicate but should amplify activity at local authority level. So I do think there's some opportunities there through the devolution arrangements, but clearly there's lots of different places at different points on the journey. There's varying levels of capacity and resources, and there's as we all know, there's a lot of change that will happen. But I think trying to work early on with those new systems and think about what the respective roles are, obviously thinking also about ICBs and the new NHS structures and being clear on how they all add up to being more than a sum of their parts, I think is quite critical.
Okay, so one final question for everybody. In terms of your roles in being champions of health in all policies, what is the next thing that you're going to be doing to help move this forward, either at a national level or at a local level? Catherine.
So going back to the point I made earlier about, I think there needs to be some health and all policies approach at national government, continuing to call for that greater level of join up that should support level of join up across the rest of the system.
Thank you. Kate, what next for Cornwall?
So I think what am I thinking here? I'm thinking we've got a big opportunity with the local government outcomes framework coming forward around making sure that that really picks up on those areas where we could see that we have embedded health in all policies. So I think continuing to draw the connections and the threads between these pieces of work.
Thank you. And Sonia for Glasgow.
Thanks, Louise. So I suppose in Glasgow City Region, the two obvious ones. One is the continued engagement with the Scottish Government in their population health framework to try and also work with the local authorities in the city region and build that critical mass in terms of health in all policies approach to support the national priorities, working with both local and national organisations to build capacity and to achieve that approach, and to really continue to support the implementation of the HiAP as a means to an end, to gather collective support around the approach, not as an additional burden, an additional thing that people have to consider, but something that they do as part of their decision-making processes. And finally, in terms of the regional economic strategy, which I alluded to earlier, we are looking at how we refresh the monitoring and reporting of all the 15 programmes that integrate that. So again, building health in all policies as a golden thread that helps us to achieve all the key areas within the missions of the strategy, from building a thriving economy to looking at health and the economy, to building resilience to climate change. So helping us to reach those through that health in all policies approach as a cohesive approach.
Thank you, Sonia. And finally, Michael, what's next for you?
Thank you. So using the baseline understanding of all the local plans and obviously a stronger national planning framework around healthy lives, but also provision of health infrastructure, we can really try and influence local plan reviews going forward. Less than a third of councils have an up-to-date local plan, and therefore the other 2/3 are or will be updating their local plans. So now's a good opportunity to embed health promoting policies in those local plans.
Thank you, Michael. That's a really good point for everybody who's on the call. And just to say, all the links and the slides and everything will be shared afterwards. I'm really pleased that we have got someone from the Local Government Association here today, Kay Burkitt, who is Senior Advisor for Public Health and leading Healthier Places. And Kay is going to give us an overview of the Local Government Association's health in all policies, the improvement and support offer that we've got. So Kay, if you could come in and give us a bit of information about that would be fabulous.
Yes, thank you so much, Louise, and good afternoon, everybody. So if you're at the start of thinking about your ideas around health and all policies, or if you're wanting to crystallize your ideas, or you've been inspired by our contributors today, and you're in a local authority, a combined authority, you're thinking about devolution, local government reorganisation, the LGA has been providing support in this area for over 10 years now. There's so many examples out there of fantastic work that's taken place across local government. And we've got, this is what makes people sit up and listen, we've got a free offer. And so if you're in a local authority and you want some support to implement health and all policies, then we're here to help you. So I've got a couple of slides, if that's okay, Louise. I'm going to jump on to the next slide after this one, if that's okay. So here's a quick summary of what's currently on offer. It's supported by Department for Health and Social Care. So it's free to councils for this financial year. We provide tailored support like workshops around health and all policies. We can do it through any lens at all. And what we're looking at is enabling councils to kind of get that strategic buy-in and think about what health and all policies means for them within the council, and also the work they're doing at system, place and neighbourhood level. So that's completely kind of bespoke and tailored according to the context and each local authority or groupings. We also have web pages, lots of case studies there. We've just updated the Health and All Policies manual. So that's something to have a look at with some really practical suggestions in there. All the links will be provided, as Louise said, after this webinar. And one of the things that I would want to promote, which is not the next slide, but the slide after, if we could just jump to that, slide 5, which is the National Health and All Policies Network. This has been set up with and by public health consultants across local government in England. We've got over 150 members of that. And here's a place where lots of really good and practical ideas and tools and approaches are shared on a regular basis. There's a bulletin. There's some examples there on the slide. You know, Catherine at the start outlined some of the support from the Health Foundation. There's a lot out there to help you to think about how you want to kind of take forward your aspirations around health and all policies through whatever lens you might be looking. So if you don't have representation on this group, I would urge you to do that as well. So that's a very quick run through from me, Louise. I hope that's helpful, and my email will be provided as the information goes out after this webinar.
Thank you, Kate. So if somebody wanted to join the network, is that something that they could do? Because that, you know, I'd highly recommend that as a way of keeping in touch and finding out what other people are doing.
Yeah, absolutely. Just need to email me, Louise, and we will. But it's aimed at local government, just to be clear. That is their own network around that. Yeah, just email me and I'll make that happen. Thank you.
Okay, that's excellent. Thank you very much. Well, that's all we've got time for today. I'd like to say a massive thank you. If we're in a big room, we'll probably give all our speakers a big round of applause. So a virtual round of applause to everybody who's participated today. And I hope you've really benefited from this afternoon. I always do on these sessions. I've scribbled some notes, which I'm going to take away and think about what we need to do in our local authority, but also some more in terms of the LGA and what more we can be doing. So whether you're at the start of your journey for health in all policies, or you're halfway through, or you're really sort of powering ahead, I wish you every success, because together we will change people's lives, and that's really what keeps me going and drives me forward. So great to not see you all, but know that you've all been there this afternoon. Hope you've enjoyed us, and join us again soon sometime. Okay, thank you and goodbye.